Assalamualaikum and good day. Today we are going to look at a group of lung diseases called chronic diffuse interstitial lung disease. We are also going to look into acute lung injury and ARDS. At the end of this session, students should be able to describe the common chronic diffuse interstitial lung diseases, describe the pathogenesis of common pneumoconiosis, describe the pathogenesis of pulmonary edema, and describe the pathogenesis of acute respiratory distress syndrome. Chronic diffuse interstitial lung disease is a group of disorder characterized by inflammation and fibrosis of the pulmonary connective tissue, and it is divided into 5 major categories: fibrosing, granulomatous, eosinophilic, smoking-related, and others. We are going to look at a few of these in this lecture. The clinical and pulmonary functional changes that we see in interstitial lung disease are of restrictive lung disease. The problem in restrictive lung disease is the inability to fill the lung. Compare this to the problem in obstructive diseases, which is the inability to empty the lung. If you can't fill the lung, obviously the total lung capacity will be low. The forced vital capacity will also be low. The ratio of FEV1 over forced vital capacity is actually increased or normal. The reason is, in restrictive lung disease, there's often a lot of fibrosis in the lung, and that increases the elastic recoil, which allow air to be squeezed more out quickly in the first 1 second. Eventually, there will be increased pulmonary vascular resistance that causes secondary pulmonary hypertension and right-sided heart failure. Forced vital capacity is the amount of air that you can blow out after breathing in all the way. If you can't bring air in the lung, you can't get much air out. FEV1 in 1 second will also be reduced. That is, the amount of air you can blow out in 1 second after breathing in all the way. If you can't bring air in the lung, you can't get much air out. It's important to note that in a normal person, the FEV1 is about 4 liters and the FVC is about 5 liters. The ratio will be 80%. Because FVC goes down much more than FEV1, the ratio in restrictive lung disease will be more than 80%. This is the classic hallmark of this disorder. In obstructive disease, the ratio is decreased. The wall of the alveoli is super delicate and thin. The reason you want it to be very thin is for oxygen and carbon dioxide exchange across the wall. In interstitial fibrosis, the fibrosis occurs in the interstitium, and this will thicken the wall, which will affect the exchange of gases. Carbon dioxide can increase, oxygen will decrease, patient will present with dyspnea, tachypnea, and cyanosis. Filling of the lung will also be affected because it's harder to expand a fibrotic lung. And this causes the restrictive problem, which is the inability to properly fill the lung with air. Idiopathic pulmonary fibrosis is a syndrome marked by progressive interstitial fibrosis, destruction of lung tissue, and respiratory failure. It accounts for around 30% of cases of restrictive lung disease. The key features here is fibrosis of the lung interstitium. The etiology is related to cyclical lung injury. When there is cyclical or repeated lung injury, there will be cyclical healing by fibrosis. The injured pneumocytes produce TGF-beta that induces fibrosis. If patients have interstitial fibrosis,
We have to exclude other causes such as bleomycin, amiodarone, radiation therapy, and others. Once all the other causes are excluded, then we can call it idiopathic pulmonary fibrosis. Grossly, we can see cobblestoned pleural surfaces due to scarring, just like what is seen in the blue arrow. Subpleural and interlobular septal fibrosis can also be seen. Honeycombing is seen, especially at the orange arrow. This is what it classically looked like under the microscope. There is only one area that is close to normal in this picture. The normal wall of the alveolar sac is very thin and delicate, just like the one near the orange arrow. The other alveolar sac has very thick fibrotic wall, as shown and pointed by the green arrow. This is a picture of high-resolution CT of the lung in idiopathic pulmonary fibrosis. Note the honeycomb appearance of the lung caused by excess fibrous tissue in the interstitium. Compare this with the gross and microscopic pictures we have just seen.
Clinically, the patients will have shortness of breath, which gets worse over time because the fibrosis gets worse over time. At the same time, they are going to have cough. The lung CT would show fibrosis. The fibrosis starts at the subpleural region and eventually over time it can progress to involve the entire lung. Hypoxemia, cyanosis and clubbing is seen later. There will be gradual deterioration in pulmonary status. When it involves the entire lung diffusely, it's called honeycomb lung. 40% of patients eventually die of respiratory failure with a mean survival of 3 years or less. There is no way to remove the fibrosis, so the only definitive treatment at the moment is lung transplantation. Now we look at other entities of chronic diffuse interstitial lung disease. The first one is non-specific interstitial pneumonia, or NSIP. It is similar to idiopathic pulmonary fibrosis. However, the patients tend to be women and girls. It is often associated with connective tissue disease, certain drugs, hypersensitivity, pneumonitis, and HIV infection. NSIP has better prognosis than idiopathic pulmonary fibrosis. The next entity is respiratory bronchiolitis interstitial pneumonia, RBIP. It is more common in men and smokers and is usually present in people around 40 to 60 years of age. Cessation of smoking often leads to improvement of RBIP. Other types of chronic diffuse interstitial lung disease includes desquamative interstitial pneumonia and cryptogenic organizing pneumonia. DIP has a strong association with smoking, with 90% of the cases are associated with cigarette smoking. Patients will have insidious onset of cough and dyspnea. Cryptogenic organizing pneumonia has biopsy findings of proliferation of immature bodies or meson bodies and fibrous tissue in the bronchioles. Patients with cryptogenic organizing pneumonia respond very well to systemic corticosteroids. Another important group of disease in the restrictive lung disease is the pneumoconiosis. Pneumoconiosis is a group of lung disease that are non-neoplastic, and it is a reaction to inhalation of mineral dust, organic dust, chemical fumes, and vapor encountered mostly at workplace. It requires chronic exposure to small particles that are fibrogenic. This has to be small enough to reach the exchange area of the lung, which will then induce the fibrosis in the interstitium. The fibrosis is mediated by alveolar macrophages, which consumes the particles and induces the fibrosis. Exposure to the big particles usually will be filtered by mucus and cilia of the respiratory tract. The main cause of pneumoconiosis are the coal dust, the silica and the asbestos. Exposure to silica causes silicosis, asbestos causes asbestosis, and exposure to coal causes coal workers pneumoconiosis or anthracosis. The particle size determines the site of lung deposition of the material. Particles smaller than 0.5 micron reach the alveoli and are phagocytosed by alveolar macrophages. Coal dust is the least fibrogenic particle, and silica, asbestos, and beryllium are very fibrogenic. Coal workers pneumoconiosis are a group of lung disease that are caused by inhalation of coal particles and other forms of dust. Chronic exposure to carbon can cause fibrosis. The fibrosis is mediated by alveolar macrophages, which consumes the carbon particles and induces the fibrosis. Sources of coal dust are from coal mines, large urban centers, and tobacco smoke. There are three types of coal workers pneumoconiosis: asymptomatic anthracosis, simple coal workers pneumoconiosis, and complicated coal workers pneumoconiosis. Coal workers may also develop emphysema and chronic bronchitis independent of smoking. There are also asymptomatic anthracosis, which are commonly seen in urban dwellers and tobacco smokers. Simple coal workers pneumoconiosis are characterized by presence of fibrotic areas. They are small in the upper lobes and the lower lobes. The coal deposits near the respiratory bronchiole to produce centrilobular emphysema. Complicated coal workers pneumoconiosis, on the other hand, have multiple blackened scars up to 10 centimeters in diameter, and they have fibrous tissue which are composed of collagen and pigment. Kaplan syndrome may occur, and there is increased incidence of lung, colon, and urinary bladder cancer in these cases. Coal workers pneumoconiosis are usually benign, causing little damage in lung function. However, in 10% of patients, complicated coal worker pneumoconiosis causes progressive massive fibrosis, which can lead to increasing pulmonary dysfunction, pulmonary hypertension, and cor pulmonale. Coal dust increases the incidence of chronic bronchitis and emphysema. Silicosis is a common lung disease caused by pro-inflammatory crystalline silicon dioxide, or silica. It usually presents after decades of exposure as slowly progressive nodular fibrosing pneumoconiosis. People who are at risk are individuals involved in repair, people who are involved in demolitions of concrete structures such as building and roads. This is the most common occupational disease in the world. Silica is very fibrogenic and primarily deposits in the upper lung. Silica activates the alveolar macrophages, which release cytokines that stimulate fibrosis. In the early stages, small nodules in hilar lymph nodes and upper zones of lung appear. As the disease progresses, the nodules coalesce into hard collagenous scars. If the disease progresses further, it may produce progressive massive fibrosis. The picture shows advanced silicosis. The scarring has contracted the upper lobe into small dark mass, as shown in the arrow. In the early course of silicosis, the pulmonary function are either normal or only moderately affected. Most patients do not develop the shortness of breath until progressive massive fibrosis occurs. Having silicosis increases the risk of contracting tuberculosis and lung cancer because the crystalline silica may inhibit the ability of the pulmonary macrophages to kill the mycobacteria. The onset of silicosis may be slow and insidious. It takes about 10 to 30 years after exposure. It could also be accelerated within 10 years of exposure or rapid within weeks or months after intense exposure. Patients with silicosis have double the risk for developing lung cancer. Asbestosis or asbestos exposure is seen in construction workers, plumbers, and shipyard workers. Family members of asbestos workers have an increased incidence of asbestos-related cancer. It causes a number of diseases like localized fibrous plaque, recurrent pleural effusion, parenchymal interstitial fibrosis, lung cancer, mesothelioma, laryngeal cancer, and ovarian cancer. In other words, it causes fibrosis in the lung, fibrosis in the pleura, cancer in the lung, and cancer in the pleura. Remember, cancer in the pleura is called mesothelioma. The disease-causing capabilities of the different forms of asbestos depends on its concentration, its size, its shape, and solubility. Asbestos occur in two distinct forms, serpentine and amphibole. The amphibole type are more pathogenic because it can penetrate deeper to the interstitium, and asbestos fibers prefer to localize in the distal lung, close to the mesothelial layer. Asbestos can act as tumor initiator and tumor promoter. Its oncogenic effects are mediated by reactive free radicals generated by the asbestos fibers. Toxic chemicals can attach on the asbestos fiber. Carcinogen from tobacco smoke can adhere on the asbestos fiber. The asbestos workers have five-fold increase in lung cancer incidence. There is synergy between asbestos and smoking, which can increase the risk of lung cancer to 55 folds. Asbestos fibers are coated with iron and is called ferruginous body. This seen here, the golden brown fibers with brown beads on it. The brown beads represent iron. The macrophage will attempt to ingest and clear the fibers, but this will activate fibrogenic mediators as an immune response. There will be chronic deposition of fibers and persistent release of mediators, leading to generalized pulmonary inflammation and interstitial fibrosis. Clinical findings in asbestosis commonly takes 20 years to manifest itself. Dyspnea or shortness of breath is the first symptom, initially dyspnea via exertion, and then dyspnea at rest. There will be associated cough with production of sputum, and the disease can progress to congestive heart failure, cor pulmonale, and death. Asbestosis may be complicated by the presence of lung or pleural cancer, which gives very bad prognosis. Now we move to another type of disease, which is granulomatous disease or sarcoidosis. The sarcoidosis is a systemic disorder of unknown etiology characterized by formation of non-caseating granulomas in many organs of the body. The most common presentation in 90% of the cases are bilateral hilar lymphadenopathy or lung involvement. Diagnosis of sarcoidosis is one of exclusion. We should exclude other causes of granulomatous disease, such as tuberculosis, fungal infection, or others, before concluding diagnosis of sarcoidosis.
Sarcoidosis is a disorder of immune regulation. The major histocompatibility complex genes and non-MHC genes have been located on the short arm of chromosome 6. There are genetic risk factors for sarcoidosis. CD4 T helper cells interact with unknown airborne antigens and causes the release of cytokines from T helper cells, resulting in the formation of non-caseating granuloma.
The lung is the primary target organ for sarcoidosis. Granulomas are seen in the interstitium as well as mediastinal and hilar lymph nodes.
Histologically, non-caseating granulomas composed of aggregates of epithelioid macrophages with Langhans or foreign body type giant cells and Schaumann bodies and asteroid bodies can be seen. The pathologic involvement can be seen in every organ in the body, but the lung is the primary target. This is a picture of the asteroid body, which can be seen in sarcoidosis. And this is Schaumann bodies, which are concentric calcifications. Most patients with sarcoidosis are asymptomatic, and they are just discovered unexpectedly as bilateral hilar lymphadenopathy, as in the picture. They may present with peripheral lymphadenopathy, cutaneous lesions, eye involvement, splenomegaly, hepatomegaly, shortness of breath, cough, chest pain, hemoptysis, and constitutional signs and symptoms. Patients may have elevated angiotensin-converting enzyme, or ACE, which are increased in 60% of patients. They may present with hypercalcemia because the granuloma has the increased synthesis of 1-alpha hydroxylase activity, and this can activate vitamin D. The treatment of sarcoidosis is steroid. Sarcoidosis can be progressive or may be alternating between active disease and remission. 20% of patients have permanent loss of lung function, and death may be due to progressive pulmonary fibrosis and cor pulmonale. Pulmonary edema is the accumulation of fluid in the alveoli of the lungs that results in poor alveolar gas exchange and breathing difficulties. It can result from hemodynamic disturbances, such as from increased hydrostatic pressure in the pulmonary capillaries. The most common cause of this is left-sided heart failure. Another cause of hemodynamic disturbances is the decreased oncotic pressure from hypoalbuminemia. This can be caused by nephrotic syndrome or hepatic cirrhosis. Pulmonary edema can also be caused by microvascular injury, such as from infection, aspiration, drugs, and acute respiratory distress syndrome. Grossly, the lung with pulmonary edema is a heavy and wet lung, and the fluid usually accumulates in the base of the lower lobes. As you can see in this picture, these are the alveolar spaces, and it's supposed to be empty with white spaces in between. So now it has this pinkish material. These are fluid. So the alveolar spaces are filled with fluid now. And you see the alveolar capillaries are engorged with red blood cells. So with time, if this doesn't resolve, there's going to be fibrosis, and this condition predisposed to infection. Now we move to the topic of acute lung injury and acute respiratory distress syndrome, or ARDS. Acute lung injury, or ALI, and ARDS is also known as non-cardiogenic pulmonary edema. Is characterized clinically by acute onset, which is within 1 week, significant hypoxemia or low oxygen level, bilateral pulmonary infiltrate on imaging, and in the absence of cardiac failure or fluid overload. Although the term ARDS is often used interchangeably with acute lung injury, or ALI, ARDS is the most severe form of the disease. You can compare the upper picture of the X-ray with the lower picture of the X-ray, which is from a normal person. You can see the infiltrate is occupying almost all the areas of the lung. These are the major causes of acute lung injury and ARDS.
sepsis and pneumonia are the most common causes. This includes COVID-19 viral pneumonia-induced ARDS, which is a severe form of COVID-19 clinical manifestation. Gastric aspiration accounts for more than 30% of the cases, while severe trauma with shock accounts of more than 20% of cases. Look at picture A. The injury of the alveolar capillary unit may begin at either the endothelial or the alveolar side of the unit. The neutrophils either inside the alveoli, as in the cases of pneumonia, or in the alveolar capillaries, as in the cases of sepsis, play a major pathogenetic role and mediate the injury of the alveolar capillary unit. The neutrophils adhere to activated endothelium and migrate to the interstitium and alveoli. They degranulate and release mediators such as reactive oxygen species, cytokines, and proteases. More leukocytes are recruited, causing more injury, and this repeats the cycle of inflammation. Now we look at picture B. The injury leads to increased permeability of the alveolar capillary membrane and pulmonary edema formation. This is often followed by intra-alveolar hemorrhage and deposition of fibrin or hyaline membranes. The destruction of capillary alveolar units leads to hypoxemia. ARDS has three pathological phases: exudative, proliferative, and fibrotic phase. In exudative phase, the respiratory symptoms usually start within 6 to 72 hours after exposure to the risk factors, and this progresses rapidly, usually lasting about 7 days. In proliferative phase, it usually lasts from 7 to 21 days, and many of the patients will recover within 3 to 4 weeks after the lung injury. Fibrotic phase is the phase that has a high mortality rate. Some of these patients from proliferative phase progress to fibrotic phase, where the exudates are converted into extensive ductal and interstitial fibrosis. Now we look at what happens in the exudative phase. The exudative phase is characterized by destruction of type 1 alveolar cells and the capillary endothelial cells. This results in the loss of the tight junctions that prevent the movement of fluid and macromolecules into the alveoli. So as you can imagine, that this leads to the fluid aggregation, plasma proteins coming into the alveolar spaces, and cellular debris also comes into the alveolar spaces. And together, it causes the dysfunction of the pulmonary surfactant. And all this ultimately lead to the formation of hyaline membrane walls. You can see the hyaline membrane on the walls of the alveolar surfaces. After the exudative phase, the lungs will go into proliferative phase, where the type 2 pneumocytes proliferate. You can see in this picture, there's proliferation of cells, and they're made up of type 2 pneumocytes and also granulation tissue that forms within the alveolar walls and spaces. In most cases, the granulation tissue resolves after a week or two, leaving minimal functional impairment. So you will get back the alveolar spaces, and the lung function will return more or less to normal. However, in some patients, fibrosis will occur in the alveolar septa, as you can see in this picture. There's organization of the fibrin and resulting into fibrosis. Yeah. So the patient goes into the fibrotic stage. So you can see that in this patient with fibrosis, the lung function will be deteriorating because there's no alveolar spaces for respiration to occur. So the clinical features of ARDS: in acute phase, patients with ARDS typically present with dyspnea, cyanosis, and diffuse bilateral crackles, because in acute phase you will have a lot of fluid coming in. There's also increased work of breathing and using accessory muscle that may result in fatigue and respiratory failure. In proliferative phase, the patient start to recover rapidly during this phase. They still have some dyspnea and tachypnea and hypoxemia. You see that the areas are filled with granulation tissue, and there's a lot of proliferation of the type 2 pneumocytes, as we have seen in the previous slide. Some patients develop early progressive fibrosis, which is associated with increased risk of death. In fibrotic stage, many patients will develop lung fibrosis that may require long-term mechanical ventilation and oxygen supply. And this phase, as we have said, is associated with high mortality rate.
So we've covered common chronic diffuse interstitial lung diseases, and we've gone through the pathogenesis of the common pneumoconiosis, pulmonary edema, and acute respiratory distress syndrome. Thank you very much. Assalamu alaikum.